Okay. All right, great. I didn't record our little music video because I didn't think that needed to be committed to film. All right, so immune pathology. We're going to get through a couple path conditions. These are a part of your NPLEX list, which is why they're on here. If they weren't, I wouldn't include them. So X-linked Bruton A gamma globulinemia. Wow, fun. It's a defect in BTK, which includes tyrosine kinase. It is a tyrosine kinase molecule. It leads to B cells not becoming mature. So we will see then absent or small lymph nodes, that's LN, and absent or small tonsils. That's typically where B cell proliferation occurs. Ooh. It's X-linked recessive, so it is sex-linked. And you can see then, if we're not able to create B cells, if they're not able to mature, you're going to have recurrent bacterial or enteroviral infections after about 6 months in age, because that's when your maternal IgG that crossed via placenta goes away your body. If you are unable to create your own antibodies, around 6 months time is when your maternal antibodies that cross via placenta are gone. Also, live vaccines would be contraindicated in these patients. You still have innate immune system response. So you can still respond via your innate immune system, and you're not having issues with T cells. It's B cells specifically. So all of your humoral immunity, your memory immunity, all of those things are going to decrease. In X-linked Bruton, so Bruton with a B, A gamma globulinemia. In selective IgA deficiency, we can think about what it could be deficient in, right? It is idiopathic. That's kind of, it's most commonly known as we don't exactly know what causes it. It can also be asymptomatic until you get either an airway or a GI infection, which then tends to be affected the most. It is the most common primary immunodeficiency. So congenital immunodeficiency, it's the most common. You'll see decreased IgA with normal IgG and IgM antibodies. It could actually lead to your body not recognizing IgA antibodies. So if you were given IgA in blood, if you did a blood transfusion, you could have anaphylaxis to that blood because of seeing IgA for the first time. Your body can't recognize that as a self component. This can give false negatives to celiac disease. That's where we tend to see it occur the most, at least clinically, because it's not necessarily super common. So if someone had a low level of IgA or an IgA deficiency, we could see false negative celiac disease. You can see increased susceptibility to any infection of the gut, but specifically Giardia, because it likes to bind into our mucous membranes. We then have this other one called common variable immunodeficiency. So again, variable, it's going to vary. It's going to have a defect in B cell differentiation. So differentiation of our B cells into its mature components. We can see it's also idiopathic. We'll see decreased plasma cells, decreased immunoglobulins of all types. And you're going to have an increased risk then of autoimmunity conditions like bronchiectasis, lymphoma, and sinus or pulmonary, sinopulmonary infections. Chronic mucocutaneous candidiasis. I included this one just because I wanted to include candida. We'll talk about it a little bit later. But in chronic mucocutaneous candidiasis, you actually have T cell dysfunction. So it's not just normal candida infection. This will lead to, if you have abnormal T cell dysfunction, it's going to lead to impaired cell mediated immunity, because our T cells are big signalers. Our T helpers signal a bunch of other cells through cytokines, right? So if our T cells aren't working appropriately, we're not going to have any of our T helper cells working right, which then we don't get as much of a cytokine cascade. So you can actually see persistent but non-invasive candida on skin and mucous membranes in this condition. Could you have chronic mucocutaneous other conditions? Probably, but specifically the one they mentioned is chronic mucocutaneous candidiasis, because it's on the mucus and the skin membranes. And then the last one is severe combined immunodeficiency. There's several types here, but again, this is a combination of multiple immunodeficiencies, but just as it is in the name. You can see different defects here. So you can see a defective interleukin-2, specifically on the R gamma chain. That's the most common type of this severe combined immunodeficiency. It's X-linked. Overall, though, I want you, when you think of severe combined immunodeficiency, more than memorizing the specified types, I want you to think of failure to thrive, thrush, and recurrent infections. Think about a kiddo who's failure to thrive. They have lots of diarrhea, so they're not able to gain weight. They keep getting thrush, and they just continue to get sick. Those are your big immunologic congenital conditions, so big mutation conditions associated with the immune system. I do want to just show you a couple slides that I have on infections that can increase with an immunodeficient patient or immunocompromised patient, because they love asking those questions. Your patient's immunocompromised. What can happen? Well, lots. But when you're thinking about an immunocompromised patient, so someone who our chronic type typical patient we think of as someone who's maybe been treated for cancer, who's undergone radiation or chemo. It could also be HIV, but I like to think of the cancer ones, so we're not confusing microbes, right? So think of someone who's just undergone chemo radiation treatment for cancer. What bacterial infections are going to affect them depending on which part of their immune system is affected. So if we have low T cells, if our T cells are on the low end, we're going to have an increased effect for sepsis of any kind, infection of the blood. If we have low B cells, think about encapsulated bacteria are going to be your biggest effect. Why? Encapsulated bacteria contain that capsule that prevents them from getting phagocytosed. B cells help opsonize bacteria, then promoting phagocytosis and supporting still digestion and identification of that bacteria, even though they have this capsule trying to protect them. If we don't have B cells, we're less likely to be able to identify these bacteria quickly and then eliminate them. So the infection then can fester for longer and can be worse. So your encapsulated bacteria, this will come back later. This acronym is please shine, all caps, my skis. Pseudomonas, strep pneumoniae, H. flu, Neisseria meningitis, E. coli, Salmonella, Klebsiella, and group B strep. Those are your encapsulated bacteria that can kind of evade the immune system. If you have low granulocytes, your acronym could be some bacteria produce no serious granules. Staph, Burkholderia, Pseudomonas, Nocardia, Serratia. Those would be your commons that could affect you more if you're immunocompromised with this specific immunodeficiency. Or low complement would be encapsulated species, so our encapsulated list that have early complement deficiencies, or encapsulated, or you could even see encapsulated bacteria with late complement deficiencies. That's when you see Neisseria. What do I mean by late complement deficiency? I think I have too many F's there. Yeah, I do. I have an extra F. What I mean by late complement versus early complement, is there an issue in complement signaling to start that cascade? Or is there an issue later on down the road with complement conversion or actually activation of the specific complement action that that complement molecule partakes in? So remember, complement has different actions, right? So it's an issue with signaling, that would be early complement issue. If it's an issue with the function or the action of that complement molecule, that'd be a late complement deficiency. Yeah. Opsonization can happen not only from complement, right? But opsonization would be early complements, the first thing that happens. Yes. Good question. Viruses that can affect us. So I just think of low T cells and low B cells. So viruses, if we have low T cells, our T helpers and T killers are low. Cytomegalovirus, Epstein-Barr, going to be big ones. Other ones that are on your list, VZV, Varicella zoster, so shingles and chickenpox is on your list. Or in general, any chronic infection that has a respiratory or GI etiology or area of locus. Other B cell vaccines, if you have low B cells, what viruses could be affecting you? Any enteroviral virus, but polio is the big one I would want you to keep in mind. Low B cells with the virus that could affect you would be polio, or live vaccines, contraindicated with live vaccines as well. Fungal or parasitic infections. The ones that you need to that are on your list to know would be Candida, Cryptococcus, low T cells, Giardia, low B cells, Aspergillus, low granulocytes. The others, PCP, Mucor, are not on your list. All right, so let's start giving us a taste of what these things are. We're now going to get into the nitty-gritty. So on your Moodle page, I just want to show you, I have posted many different references and resources of bacteria and bugs and viruses. Oh, you can't see my screen, awkward. On your Moodle page, all kinds of references and things. We're not going to hit all of these at all, nor should we. This is really for your review. It has a comprehensive look of all the bacteria that are of medical importance, their conditions, their factors. We're going to start with our micro presentation here. It's just a general micro presentation that's going to go into our creation of a dichotomous key. And then we're going to try to hit virus, fungi, and parasites. We'll see how far we get on all of those. But we're going to go through the bacteria first, because these are the most common buggers, literally, that we will hit in the NPLEX. Moving this back. Okay, micro, NPLEX 1. This is your beautiful, I teach micro and for an undergrad grad group. And so we are growing our own bacteria and microbes, and they have a identification process where they're given 3 unknown bacteria and they have to identify them using micro tests, which is really helpful to see actually what these tests mean. So we learn about gram positive, gram negative, catalase positive, parasites, what does any of this mean? So we're going to talk a little bit briefly for what you need to know about what does catalase positive look like. So hopefully it'll give you a little memory tool, but I'm not going to teach you how to do these tests because you don't need to know that for the NPLEX. If you're going into a lab, if you're going into research, you might need to do some of these stuff, depending on if you go into microbe research. I don't know what you're interested in, but we can talk about that later. You can come help me make some culture feature dishes. Takes me hours. Okay. That's an aside. All right, so a few bacterial genetic pieces. I'm not going to hit too hard on this, but I just want you to know the words, the terms that we're talking about here. So 4 words that are important when it comes to bacterial genetics. It's transformation, conjugation, transduction, transposition. These words ring a bell at all? Yes, we've heard of them. We kind of have an idea. So we're going to do general surface level info, because this is not a genetics test, nor is this a micro test, but they could ask you some questions on bacterial replication, or they could throw these terms in to see if they could mix you up on a question. So transformation, essentially bacteria are able to bind, import short chromosomal DNA sequences into their host cell, which then can become replicated. The key here is it's short, they're binding to do this, and it's not full sequences, it's a short little component of DNA, chromosomal DNA. Bacteria that are especially good at this is your strep pneumoniae, your H flu, Haemophilus influenza, and all your Neisseria species. So your meningitis, your gonorrhea species. Conjugation, think about this as having a bridge. There's a highway between 2 cells, and one cell is sending a single strand of plasma DNA transferred across that conjugal bridge to the other cell. So conjugation, actual transfer down a connected highway and path, versus transformation, bacteria is just binding shortly and importing a little tiny snippet of its bacterial chromosomal DNA. Conjugation's plasmid DNA, also a different type of DNA, not chromosomal DNA. Many bacteria do this. If they have there's a specified component of a bacterial cell, which we'll look at. Then transduction, some type of lytic phage, it's going to infect a bacteria. Then it's going to lead to cleavage of its own bacterial DNA. Then the capsule from that phage, the virus, can contain some bacterial DNA by accident. Then that bacterial DNA within that virus is going to be transferred to a new cell. So that's usually how you have viral transfer of bacterial DNA to another cell. Some bacteria that are especially common to do this, group A strep toxins, so all your toxins, botulinum toxin, cholera toxin, diphtheria toxin, sugar toxin. If you think about toxin, think about transduction. occurring. And then you have transposition. Lots of your drug-resistant strains love transposition. This is how we get lots of different drug-resistant issues. A DNA is able to copy it, excise itself, and insert itself into another DNA molecule. It's able to evade and change on its own. It's able to excise certain portions, transpose them elsewhere. It's how we can have drug-resistant strains that can evade different antibiotics or antimicrobials. Overall, bacterial genetics bacteria are really good at mutating and creating new ways to evade the immune system. And these are 4 different ways that they do it. Now, as we go through this presentation and the next few presentations, I want to encourage you to play along with this activity, but you do not have to. Something you can do at home if you'd like, and you'll probably make multiple different versions of these. But we're going to create some dichotomous keys today. Dichotomous key is a flow chart to identify bacteria. It really is just going to help you separate in your brain different types of bacteria and their components. And you can have a dichotomous key. The goal with a dichotomous key is typically to start with a group of bacteria and end up with each pathway leads to one bacteria on its own. For the NPlex, you'd probably be safe with getting down to the generalized category of bacteria. So if you can get to the Necessariae category and then be able to tell clinically the difference between gonorrhea versus meningitis, you'll probably be in the clear. If you can get down to the strep category and then clinically be able to tell between viridans, pyogenes, pneumoniae, based on what their clinical causes, you'll probably be fine. So we're going to go, our goal is going to be to get to these specific categories. And then if you want to differentiate based off of labs or components of the virus or the bacteria, that's fine. But I'd encourage you, once you get to the category of strep, to then go clinical and think what makes strep pneumonia different from strep viridans versus from strep pyogenes, or staph aureus different from staph epidermidis, different from staph saprophyticus. All right, and if none of those make sense to you, it's okay. It's fine. If you can get to strep and staph and differentiate those two, you'll be doing yourself a good service. Okay, so that's what we're going to work on. There's no right or wrong answer for a dichotomous key. There's just better ones and worse ones, right? Some that make more sense to your brain. But as long as you're using categories correctly, as long as you're saying, okay, these are my gram positives and I know this, these are my gram negatives, that's fine. But you can have a dichotomous key. There's nothing that doesn't matter what you put into it. What helps stick it to your memory the best. And I'll show you what that means here shortly. So things that can be included in a dichotomous key is lots of stuff, right? But you're not going to memorize every single component of a bacteria on this list for every bacteria you have. You are not microbiologists. That's not your point. That's not your purpose. So things that we'll definitely include is shape. Is it bacilli? Is it cocci? Is it rods? Is it branching? Diplococci? What characteristics does it have? This is helpful for evading the immune system, right? Endospores we've talked about, encapsulated. Acid fast, what does that mean? We'll talk about it. Motility, can it move away from your immune system and travel, or can it not? Oxygenation tells you where it's going to be in the body. Does it need oxygen? Is it aerobic? Does it not want oxygen? Is it killed by reactive oxygen species? Anaerobic? Or can it do either? Ooh, yikes. A lot of them can do either. Then there's the special tests. You don't need to know all these special tests. Microbiologists do, but we'll definitely focus on catalase, positive or negative. And some of these others can tell you about the metabolism and the biomechanics of bacteria. We don't really care for the purposes of NPlex. But you'll see sometimes these dichotomous keys, they'll talk about urease and citrate and MR. You're like, what is all this stuff? It's just different ways of identifying, throwing different chemicals at bacteria and seeing how they respond. Okay, that's what all these tests do. Hemolysis status, alpha, beta, gamma, that's important when it comes to strep identification. So we will talk a little bit about that. And then growth on specific mediums, this can tell you what could maybe kill it. Same with antibiotic susceptibility, right? Which antibiotics can kill these bacteria and which can't. This will come more into play in NPlex 2, not NPlex 1. That's when they'll care more about, you know, what antibiotics can affect these bacteria better. Fermentation, sugar use, again, don't care what temperature, might be important. So you can use any of these when making your dichotomous key. You can use none of them when making your dichotomous key. But I encourage you to start playing. We're going to give you some lists of bacteria here on the next few slides, and then this is what you're going to use to help categorize. So first, what is a gram positive or gram negative? We have to start there because this is how we start categorizing every bacteria that we pretty much talk about. So gram-positive or negative is our first line lab test in bacterial identification. What it does is it's taking 4 different stains and it's putting them on bacteria at certain time intervals. And it's seeing which bacteria take up purple, which bacteria take up pink. The bacteria that take up purple have a thick peptidoglycan, so peptidoprotein, peptid, glycan sugar, thick peptidoglycan protein carb layer that retain this crystal violet purple stain. That means they're gram-positive. They have a thick wall. Bacteria that have a thin layer, they don't have as much of a thick peptidoglycan layer. Their membrane is thinner. They're going to not retain purple stain. They're going to retain pink stain or red stain, and they're going to be gram-negative. So purple is positive, pink is negative, or red's negative. But purple is positive. Purple, thick layer, thick outer layer, cell wall. You're going to take up stain. Red, thin outer cell wall, less likely to take up stain. Now, some bacteria don't do well with either, and these would be ones that you wouldn't necessarily be able to classify as gram-positives or gram-negatives. So if you like acronyms, this is an acronym for you. These little microbes may unfortunately lack real color, but are everywhere. The ones you'd really need to know would be treponema, syphilis, leptospira, maybe, mycobacteria, yes, mycoplasma, possibly, ureaplasma, legionella, rickettsia, chlamydia. Okay, so far I'm pretty much underlying all of them. Bartonella, maybe, anaplasma, and Ehrlichia, no. So these ones don't care about. Maybe this one. So pretty much you might need to know any of them. But that's how micro goes, right? You might need to know them all, but some are more important than others. But we're going to first start on your gram-positives and negatives because most of the time, those are going to be the ones that you're asked about the most commonly. Could you be asked about non-gram-positive negative? Yes. But we'll start with gram-positives and negatives here first. So for your dichotomous key, I would suggest creating one where you're going to have all your bacteria and your first line is going to be gram-positives and gram-negatives. And then you're going to list your bacteria next to it on that list. And obviously you're not going to have this on the screen forever, so you'll have to reference it yourself. But you're going to list your bacteria that are gram-positive next to your little plus sign. You can maybe abbreviate. So if you're Actinomyces, your Bacillus types, your Clostridium, that's supposed to have an S, not clot. Clostridium, an S, Stridium, et cetera, You'll list your gram-positives and you'll list your gram-negatives. The gram-positives, big ones here on this list, Bacillus, think about anthrax, Clostridium, our Enterococcus, they like to affect our gut. Mycobacterium, because it's different, and your staphs and your streps, because they're the most commonly asked about. Are the others important too? Sure. That's why they're on this list. If they're not on the list, I don't have them as being as important. So there are more bacteria than this that are gram-positive. I only list the ones that have clinical relevance for that would likely come up on your test. So this would be your gram-positives. They're going to turn purple like this. Gram-positives purple. They have a thick wall, thick protein sugar wall. Your gram-negatives, there's a lot more to contend with. You have Enterobacter, you have E. coli, H. flu, H. pylori, lots of gut stuff. Oh, Proteus, we remember Proteus, Salmonella, Serratia, Shigella, Vibrio, Yersinia, gonorrhea, meningitis. None of these are great. None of the bacteria are great, but none of these are good. Gram-negatives can tend to affect and colonize gut. GU, GI is what I tend to think of, but of course they can colonize other places. Gram-positives, you think more of like respiratory or skin, but they can also colonize other places. These are generalizations, right? And we'll see why there's some generalizations here when we think about what are some components that make these bacteria special. Oftentimes what I'll do here in my dichotomous key is I'll start breaking things down by shape, which we'll talk about different shapes. But there's your big 2 different shapes that you'll have will be cocci and rods. So if I was going to categorize things next, I would look up what are cocci bacteria and what are rod bacteria. And lucky for you, there's presentations on both. You can go and see PDFs online that I have that show what are your gram-positive cocci, what are your gram-positive rods, and vice versa. This is a great categorization because oftentimes when they talk about the bacteria, they'll talk about shape and gram-positivity. And that's what the two things you'll get. And then they'll list some type of clinical component. Maybe they'll give you another hint about its metabolism or a special test. But oftentimes they'll say gram-positive cocci that causes XYZ symptoms or causes this condition. Or you'll get what's the most likely etiology of endocarditis in a healthy valve versus what's the most likely etiology of endocarditis in a pathogenic valve. Do you remember? What's our most cause of endocarditis in a healthy valve? It's a gram-positive. Staph, what type? Aureus, yep. What about in a unhealthy valve? Associated with dental procedures. Not epidermidis, but good guess. It's on that. Viridans, strep viridans. Good. Both gram-positives. We will talk about the difference there, but one's catalase positive, one's catalase negative. So oxygenation status. Once you've gotten your categories into cocci rods, often your next step will be deciding of these, which ones are aerobic versus anaerobic versus facultative aerobic or facultative anaerobic. And you might not find that there's all three categories. Sometimes you just have anaerobic and facultative. Sometimes you just have aerobic versus anaerobic. But anaerobes can't breathe fresh air. They're bacteria that are actually killed or harmed by oxygen, by reactive oxygen species. So your big ones, Clostridium, would be your probably biggest category of bacteria that we're going to talk about. Clostridium. So again, what was Clostridium? Clostridium was one of our gram-positives. Clostridium anaerobe does not do well with oxygen. We're probably not going to see it in places where oxygenation is freely flowing. We're probably going to see it in places where it can tuck away and hide. In the GI tract, it's normal. It can be part of our normal flora. It'll be pathogenic elsewhere if we run into it. It lacks catalase or superoxide dismutase. So that's why it is affected by reactive oxygen species, because it can't break them down. Remember, I told you in that immunologic pathway, if a bacteria is catalase positive, it's able to stop being broken apart by reactive oxygen species. These anaerobes do not have catalase, they're catalase negative. They are not able to disrupt that process, so oxygen is going to harm them. They typically have a lot of odor because they have short chain fatty acids. So they're more lipid based, so they smell, and they'll produce gas like carbon dioxide and hydrogen in tissue because they're undergoing anaerobic fermentation or anaerobic respiration. Facultative anaerobes is your biggest category. So when in doubt, assume it's a facultative anaerobe. Okay, it's going to be the most of the bacteria are going to be facultative anaerobes. There's only a few true aerobes. There's only a few true anaerobes. So facultative is by far going to be your biggest category that most are going to fall into. These can use oxygen as a terminal acceptor, or they can use fermentation. So they can exist in oxygen-rich and lack of oxygen states. Your big groups are all of your enteric gram-negatives. That's the equal sign in parentheses that can often refer to as negative, the equal sign. So strep and staph, which are gram-positives, and enteric gram-negatives, are all going to be facultative anaerobes. So some other characteristics about bacteria that can help you start to identify them. Things like flagella or fimbria. So flagella being that long tail that can help bacteria move. If a bacteria has flagella, it's probably going to be motile. Most of your motile movement bacteria, you have motile and non-motile, most of your bacteria that move or don't move are going to have some type of flagella as a part of their structure. which allows them to evade the immune system or travel in the immune system more effectively. Fimbria is going to be, when we talked about conjugation, your pilus, your fimbria is going to allow that conjugation process to occur. It's going to allow the bacteria to adhere to a cell surface of other molecules or to each other and provide transfer of some type of contents, whether it's DNA contents or it's exotoxins or endotoxins. It's going to mediate adherence and sticking to cell surfaces. The glycoproteins, you can think of it as like sugar. So sugar is very sticky, so it can stick to other surfaces. Spores, so bacteria that have spores, this is important pathology. So a spore is this keratin-like coat that occurs around bacteria. It only occurs in gram-positives. So you cannot have a spore-forming bacteria that is a gram-negative. That will not occur. So it can only be in gram-positives. Typically, your two categories that have spores are bacillus and clostridium. So if you have a bacillus or clostridium bacteria, it is spore-forming, which means it can survive in harsh conditions like dehydration, heat, or chemicals. Think about anthrax. Bacillus anthracis, anthrax poisoning, it can survive in this powdered form in its spore form. Then once it gets back into essentially a spore, it can live in this inactivated spore state for a long time. Once it gets put back into conditions it likes, like temperature, water, oxygenation or lack of oxygenation, and it has its metabolic products it needs, it will start to reactivate and become its live replicating bacteria again. So Bacillus cereus, food poisoning, C. botulinum, Botox, or botulinum poisoning, C. difficile, C. perfringens, C. tetany, tetanus. These are all Clostridium species. So Bacillus and Clostridium can create spores. They're all gram-positive. This is a great differentiation pathway. So again, if I was going through here and I had my cocci rods, and I think they're cocci. They may be rods. I have to look. I'll have to look. If they're cocci rods, my next category might be spore forming. So I'd have endospore and non-endospore, endospore forming. So gram-positives that don't have endospores, staph and strep, no endospores. So good differentiation pathway between those two. Then capsules. Capsules are different than spores. Capsules, again, mean that they have that outer covering outside their cell membrane, the polysaccharide layer, so sugar layer, that can protect against phagocytosis, that protects against the bacteria being engulfed by macrophages, and macrophages have to first opsonize bacteria that have capsules before they're able to phagocytose them. So again, our encapsulated bacteria, please shine my skis. Pseudomonas, strep pneumoniae, H. flu, our meningitis, E. coli, salmonella, Klebsiella, group B strep. 3 bacteria can even evade opsonization, which is Neisseria meningitidis, so meningitis, strep pneumoniae, common community-acquired pneumonia, and H. influenza. This is why we have vaccines for all 3 of those. The polysaccharide, the encapsulated bacteria, the actual the capsule itself is often used as the antigen for vaccines. And then we have acid-fast stains. And I only bring this up because it's specific to mycobacteria. This is a special type of stain. These bacteria tend to not gram stain well. And it's because they have very high lipid components of their cell membrane. So it's not as water soluble, it's very fat soluble. You have to use a special type of stain to actually get them to stain acid fast. You have to use an acid to essentially break down the fat to be able to have them take up the stain. So mycobacteria, Nocardia, and protozoa are your 3 most common, mycobacteria being the most common of the 3. This I only put on here is because it was a test question they used what bacteria would stain positive with a Zeal-Nelson stain? I knew acid fast, but not Zeal-Nelson. I was mad every day after that. That's why I put it here. Mycobacteria, the most common condition you would see from it would be TB. So TB is your acid fast. Biofilm producing, we love talking about biofilms because it's stuff that it's just tricky to treat, but we can do it. So biofilm producing, you have 2 strep varieties, or a staph strep, a Pseudomonas, and an H. flu. So strep or staph epidermidis, strep viridans or mutans, Pseudomonas aeruginosa, and Haemophilus influenza. And then I have what they're associated with. So your staph epidermidis, typically associated with biofilms being formed from like some type of catheter or inserted device, parasitic device. Staph epidermidis tends not to cause as much disease or dysfunction, but it can when it's associated with this external component being in our body for a long period of time. Strep viridans, we talked about that, infective endocarditis, especially associated with the dental procedure. Pseudomonas aeruginosa, think about your patients who are long timers in hospitals, so vent-associated pneumonia, or someone who is spending an extended amount of time in a hospital setting. It's often hospital acquired. It's very hard to treat and get rid of. And H. flu, actually, otitis media is your biofilm that's associated with H. flu, Haemophilus influenza. I want to spend a little time on our special tests. I promised I would. So we're going to talk about 2 that could come up most commonly is your catalase test and your urease test. Catalase test is the least exciting test I think anyone's ever performed because you have this huge buildup. You literally have the bacteria, you add hydrogen peroxide, and if it bubbles, it's positive. That's the catalase test. Okay, is it common to have false negatives or positives? 100%. So it's not a great test clinically to actually do, but it's been associated with this really easy categorization of bacteria, so we still refer to it often, but it's actually a really awful test. So your catalase test acronym, if you like the acronym world, CATs have been to places. So your catalase positive, and don't ask me how Bordetella fits in because it doesn't make sense to me, but your catalase positive, remember Bordetella pertussis, so pertussis. Your H. pylori is catalase positive. Burkholderia, nocardia, Pseudomonas, Listeria, Aspergillus, Candida, E. coli, Serratia, and staph. When in doubt, when this will come up, 95% positive, will be asking a staph or strep question, as they will say that you have a infection caused by strep pneumoniae, and they'll say, you know, they'll give you like categorizations of stuff for your questions, your answers. They'll say, is it gram positive, catalase positive? Is it gram positive, catalase negative? The gram negative, catalase positive? Is it gram negative, catalase negative? One of those horrible ones. That's how they'll ask that question. And it would be gram positive for strep, catalase negative. Staph is gram positive, catalase positive. If you have any issue in the pathway where you are like creating reactive oxygen species, or if that pathway is deficient, if you have a glutathione deficiency, if you have an NADPH deficiency, or deficiency in any of those enzymes, you can get recurrent infections by people who test positive for catalase. Because not only are they able to evade those reactive oxygen species, they're able to evade them better because you're able to produce less of them. The urease test, I just think it's fun because it turns this beautiful pink color when it's positive. So it's just very pretty. But more important than that, the urease test is important because urease hydrolyzes urea to release ammonia, not pneumonia, release ammonia, and CO2, which is going to make things basic. It's going to make things alkaline, right? So our favorite one is Proteus, right? P chunks. P chunks. It's associated with struvite stones. That's why P chunks. you're more likely to get these magnesium ammonium phosphate stones, which are struvate stones. By far, Proteus is the most common associated one that we talk about, but Cryptococcus, H. pylori again, ureaplasma, Nocardia, Klebsiella, strep or staph, epidermidis, and staph saprophyticus. So 2 staphs here are your most common urease positive bacteria. And this one they have punches. I don't know. I'm not sure what this one is. Punch kiss? I don't know. I think P chunks is easier. Maybe they're trying to do P chunks, but just I don't know what they're doing. It's fine. P chunks, I think you'll remember. But by far, I would say when asked about this, I see it most commonly asked about with Proteus, maybe with H. pylori. They might try to trick you up with a staph question, right? So they might try to do a staph bacteria that is catalase positive, but urease positive. That'd be your epidermidis and your saprophyticus, versus staph aureus would be urease negative. Ooh, tricky. I doubt they'll be in this in the weeds. These are not microbiologists writing this exam, so they probably won't go that in depth. They will want to know if someone's urease positive that you're going to be more alkaline, so more likely to produce alkaline pee or alkaline blood, so metabolic alkalosis, right? It's going to make things alkaline. If you have sepsis, a septic infection of one of these bacteria, you could set yourself up for a metabolic alkalosis state, a more higher pH state, more alkaline pH. And then I want to spend a little time on some virulence factors because they love asking about these things because they're so easy to ask about. Virulence factors are things that make the bacteria better at infecting you, right? They make the infection worse. They make the bacteria stick around longer. Whenever I talk about bacteria, I talk about them as like a human, right? The bacteria's goal is to infect a host and survive as long as it can and replicate as much as it can, right? That's the bacteria's goal. So the immune system's goal is to eliminate that bacteria. So the bacteria are going to try to evade the immune system. The immune system is going to try to attack the bacteria. And that's the dance that we do anytime we have an infection. So some virulence factors that can make the bacteria evade the immune system better. One of them is a capsular polysaccharide, which we've talked about already a few times. And again, it's highly charged, it's hydrophilic, it's a barrier to decrease phagocytosis. I bring it up because it's so important. Because it makes our immune system have to opsonize. We have to come up with a whole new system because we can't directly phagocytose. So our innate immune system has a harder time directly attacking capsular bacteria. Protein A is going to bind to the Fc region of IgG. Remember our Fc regions? We have our antibody here, and we have our Fc region is down here. So it's the non-antigen specific region of IgE or IgG. It's going to trigger that antigen to not allow it to bind. It's going to trigger that antibody to not bind to antigen then, which then is going to decrease phagocytosis and opsonization because you're not presenting that antigen on the actual antibody anymore. Your example of who does that the best, Staph aureus does it the best. So protein A, I think of A as aureus, Staph aureus. It's going to bind directly to IgG antibodies at the Fc region. It's going to prevent then opsonization and phagocytosis. So it gets to hang longer, right? It's why you can get methyl resistant Staph aureus. It's why Staph aureus can become drug resistant. It has so many ways to evade the immune system. It's very good at doing that. So then we had our protein A. Now we have an M protein. This also prevents phagocytosis. All 3 of these so far, their goals have been to find ways to prevent becoming engulfed by macrophages. There's a theme here. Our innate immune system is so good at eating up and mopping up bacteria that bacteria have come up with as many ways as possible to try to evade that system. The issue with M protein is it looks like cardiac myosin. Looks very similar to our own cardiac myosin. Myosin and actin within those muscle filaments that could do contractility of heart muscle. This contributes to the immune response in acute rheumatic fever. The body, instead of creating a complex, it's going to just identify as something that's not self as self or something that's self as not self. Because it's seen this M protein from specifically group A strep. So you get a group A strep infection. It sticks around for a little bit longer than maybe we would have liked. Maybe we didn't get antibiotics right away, or maybe we didn't get antibiotics, or maybe we're just one of the unlucky few. Our body creates an antibody or an immunoglobulin to M protein, which looks like cardiac myosin, and the body doesn't do a good enough job at separating the two. Then you have acute rheumatic fever and rheumatic heart disease, because the body is now having an autoimmune response, a type 2 hypersensitivity to self. The bacteria love that. It's called mimicry. They love to mimic stuff that's in our body, so that then we start attacking our own stuff, or we maybe don't attack them because we think it's us, right? So both directions. Most of the time, we'll just attack it anyways, and then we start to attack ourselves, which is why we can have autoimmunity. IgA protease, this is going to do what it sounds. It's going to cleave IgA antibodies, immunoglobulins. So if it does that, IgA does what? IgA helps bacteria or prevents bacteria from binding to mucous membranes. So if a bacteria can cleave this, it's going to allow that bacteria then to adhere to and start growing on mucous membranes. So we can think of strep pneumoniae as being a common one, H. flu, and Necessariae. But really, any bacteria that wants to bind and adhere and grow on a mucous membrane could potentially have this effect. IgA protease. Protease positive. They cleave IgA. Break it down. Absolutely. That absolutely could be why, because the bacteria is directly adhering to your mucous membranes. And so when you are successfully phagocytosing or sloughing them off, you're actually then also sloughing off mucus as well. Yep. Part of the pathway that then gets activated often is your reactive oxygen species pathway, which is helping try to provide some oxygenation to apoptose or kill off those bacteria. And then the ROS species, that I forget the component, but there is a component that turns your mucus green. And so that's why when you're sick with a bacterial infection, if that bacteria is susceptible to reactive oxygen species, you can see green mucus, but it doesn't necessarily mean that it's a bacterial infection. It's just any time the body's using that reactive species process, reactive oxygen species process. Typically it's with bacteria, which is why most of the time if you have green mucus, it's probably a bacterial infection, but it's not a 100%. And so then I want to spend a little time talking about exo and endotoxins, because this is also a common thing that will come up. They won't ask you about a specific bacteria, but they'll ask about a toxin associated with a bacterial illness. Yikes. So exotoxins are gram positives or gram negatives. They can occur on either or, so that's not a helpful differentiation pathway. They're directly secreted from the cell. The genes for that exotoxin are in the plasmid or bacteriophage themselves. They tend to be polypeptide in nature, highly toxic, and they're going to induce a high level of an antibody response. That's why we can use toxoids as vaccines, because we're going to create a lot of antibodies for that toxoid or that receptor portion of a toxoid. We're not injecting people with the toxin anymore forever. It's destroyed at high temps, that's 60 C, 60 Celsius, except for staph enterotoxin and E. coli. Those are heat stable or heat evading. So this would be a good differentiation pathway. But your common examples of exotoxin containing bacteria is your tetanus, your botulism, diphtheria, and cholera. Exotoxins, huge immunologic response, lots of antibodies. You're going to get a fever. You're going to get hot, because that's what can kill it or deactivate or denature it. And you can see our immune response. Bacteria secrete the exotoxins. We have receptors on our cells. These exotoxins bind here. Exotoxin receptor, then we have a reaction. The cell will die. If you have an antibody present, the antibody antigen-antibody interaction will occur instead. So you can have the antibodies that will bind to these exotoxins, and then the exotoxins don't get in the cell lives. Which is why if we can create antibodies to these toxoids, if we've seen this condition before and survived it, the next time you get infected, you will be less likely to be affected by an exotoxin because your antibodies will bind to the toxin instead of the cell directly binding, and then the toxin killing off the cell. So now I have a table. I'm not going to go through every single part of this table, but if you do want to look at what conditions would I see an exotoxin in and how would it affect the body, this is your list. So your Corneobacterium diphtheriae, so diphtheria, has a diphtheria toxin. The good thing about these toxins is most of them tell you the name of the condition or the name of the bacteria. So most of the time, 9 times out of 10, they're going to help you identify the bacteria if you have the name. Overall, both diphtheria toxin and exotoxin, which exotoxin is the one that doesn't help you, it's with Pseudomonas. Both of them are going to inhibit protein synthesis. You're going to have cell death. In diphtheria, you can see really big pharyngitis with those pseudomembranes, right? We talk about like in diphtheria, you can see almost this gray membrane in the pharynx. Severe lymphadenopathy, myocarditis, big immune response, right? We're thinking the big immune responses here. Pseudomonas, host cell death. The cells are just going to die, like I showed you in the previous picture. Shigella, Shiga toxin, enterohemorrhagic E. coli. I'm not confirmed. I think that's wrong list here. Let me just make sure. But both of these toxins here for both Shigella and E. coli, enterohemorrhagic E. coli, the specific type, they do inactivate the 60S ribosome. They're going to remove adenine from rRNA. They're going to inhibit protein synthesis. So far, all of our toxins have inhibited protein synthesis. This is going to lead to major damages to our GI mucosa, which is dysentery, which is why we'll see a big amount of loose, watery stool. And you can also see an increased cytokine release, which is why you can have hemolytic uremic syndrome. Big destruction of blood cells. You're actually disrupting protein synthesis from at its core. Then you have enterotoxigenic E. coli. This is a heat label toxin, so it's able to, it is affected, or it's able to be affected, or it's not, it's able to withstand heat. Be affected, oh, it's able to be affected by heat. Bacillus is heat stable, heat labile. It's going to be affected by heat. This is going to overactivate our CAMP process, our second messenger process in the gut. It's going to increase chlorine secretion then in the gut, which is going to increase water efflux, which is why we see watery diarrhea. You can see things like cholera, anthrax, pertussis, and E. coli all can have this enterotoxigenic E. coli heat labile toxin. Bacillus anthracis, though, it's spore forming, so it's heat stable, so it can withstand heat. It's going to do a similar response, so it's going to overactivate guanylate cyclase, so cGMP, which is going to decrease our reabsorption of sodium chloride and water in the gut. So we also get watery diarrhea. So it's the same result, just a slightly different mechanism of action. Vibrio cholera toxin. We also are going to have a CAMP issue. So we have this rice water diarrhea. That would be a pathognomonic for cholera. Rice water diarrhea, if you see that, it is cholera. There's nothing else that has that description of diarrhea. And then Bordetella pertussis has pertussis toxin, which is going to be whooping cough. So all of these conditions are watery diarrhea, a lot of our dysenteric conditions, as well as whooping cough, are going to have big immune responses from an exotoxin that's going to occur. That's why a lot of these we can be vaccinated against. Some we can't, but some we can. Few others are Clostridiums. The one that I think would be most important here would be botulinum toxin, right? Botox. Toxin, neurogenic toxin. Our streps can do streptolysin, which can degrade a cell membrane, or staph toxic shock syndrome. Either way, we're having major fever, rash, shock, food poisoning, major allergic or major systemic reaction. But I want you to think about exotoxins. Endotoxins are just gram-negative. So that's your big differentiation. Exotoxins, both. Endotoxins, just gram-negative. So when in doubt, if it's an endotoxin, you know it's a gram-negative. It's an exotoxin, it could be either or. It's not secreted from the cell. So whereas an exotoxin is secreted directly, remember exotoxins here are secreted, then they bind to the cells that they're interacting with. An endotoxin, the genes are actually in the bacterial chromosome. So our most common endotoxin that we hear about is our LPS, our lipid A component of LPS. And we'll look at what that looks like with the reaction to an endotoxin. The reaction looks the same, which is nice. This is essentially going to induce our tumor necrosis factor and our IL-1 and our IL-6. Remember IL-1, it's our big fever response in our body. They're poorly antigenic, so it's really hard for us to make a vaccine. There's no specific antigen that we can have them bind to. But these are stable in high heats for at least an hour. So these are more heat stable than an exotoxin. Meningitis and sepsis from gram-negative rods are your big bads that you want to think about. But what does it do? Endotoxins, if you're wanting to remember what an endotoxin causes, what are the symptoms that an endotoxin leads to? Edema, nitric oxide, disseminated intravascular coagulation or death, outer membrane, that's where they're on. They present on the outer membrane. They stimulate tumor necrosis factor. They're associated with three things: an O antigen, a core polysaccharide, and lipid A externally, LPS, and they're extremely heat stable. They'll also stimulate IL-1 and 6. They encourage neutrophils to go to that area, and they can cause shock. Okay. Whew. Those are the important virulent factors of bacteria. If you know those virulent factors of bacteria, and then you create a dichotomous key, which on our break I'm going to write 2 on the board for you. If you create a dichotomous key and you know what these virulence factors mean, you can identify most bacteria. And you can then even figure out what their diseases are causing or what diseases they could contribute to. Then your memorization can just be focused on specific conditions and their bacteria that's most commonly linked. Can cut down some time. But if you don't know the virulence factors, what they mean, then that's when it can get confusing. You have to memorize too much stuff. Okay. All right. I'm gonna have you take 6 minutes. So we'll come back at 11:21 or 11:22. That'll give me time to throw up a couple dichotomous key examples, and then we're going to cover a little bit of virus, fungi, parasites before we go. Okay. I'm going to keep the recording going, those online, but I'm going to turn my mic off just so you don't hear me breathing while I'm writing. let me good. I'm still on board here. Okay. So all of you should be able to see my doc cam. I just wrote up a really fast, so apologies for the writing, dichotomous key example, just so you can kind of see what this looks like. So this is for my gram positives. So you can see here gram positives, cocci versus rods. So everything in this side is going to be a cocci versus everything in this side is going to be a rod. I also separated out my acid fast bacterium, which is our mycobacterium. So that's not gonna, it will kind of lightly stain gram positive, but it's acid fast. Of my cocci being more circular, right, versus rod being more elongated. Of my cocci, I have my staph, my strep, and my micrococcus. Those are my three big categories of cocci gram positives. For my gram negatives or gram positive rods, I'm going to have my bacillus, my corneobacterium, and my, those are the two, my bacillus and my corneobacterium on this side here. So again, cocci, micrococcus, staph, and strep versus rods, bacillus, or corneobacterium. Of my cocci, catalase positive is going to be my staph and my micrococcus versus catalase negative is strep. If I wanted to differentiate my strep further, I could do hemolysis. So what does it look like under hemolysis? So it's a specialized plate, which doesn't matter for you guys. What you'll need to know is it's going to be hemolysis alpha, beta, or gamma. Gamma meaning it does none of it. Alpha is going to be your strep pneumonia. Beta is going to be your strep pyogenes, and gamma is going to be your strep mutans, which is also viridans. Okay, mutans, viridans. On your staph side, urease negative is going to be micrococcus. So your micrococcus does not cause that urease, that urea conversion. It's not going to make things alkaline, versus your staphs are going to be urease positive. Your staph, then you can break it down further by coagulation. So which staph species causes coagulation of blood cells? Staph aureus does, it's coag positive, and staph epidermidis does not, coag negative. So if you made a sheet like this of whatever things you think is most important, you can have a 1-pager to memorize versus a 94-page slideshow. That's why I encourage you to make a dichotomous key, but it's going to look different to you based on what's easiest to put into your brain and what you think the most important clinical information is to find. Of tests, these are probably the most important kind of tests or things besides potentially motility would be helpful to have on this. I only had 5 minutes. Capsules would be helpful capsules, and oxygenation. So those would be the other helpful things you could have. You could also make yourself a table and do that. Like, is it catalase positive or negative? Is it cocci or rod? Is it, what does it do for hemolysis? Things like that. A table could be helpful here. I'm very much a flowchart person or a mind mapper for me. So that's why this works. Yes. I have them as gamma, but that could be different. It could also be different book, different strokes, different years. Absolutely. Berge's manual is what we go by. It's the microbiology Bible we call. So that's what this is coming from. But again, if you're looking through USMLE, that could be what they use. They probably aren't going to use a microbiology text. So that's appropriate. Absolutely. Yes. I didn't have to on this, but you could absolutely put aerobic, anaerobic on here. I think oxygenation, capsules, and motility would be helpful to document somewhere on your sheet. But for my identification pathway, I didn't need to use that for this one, but it'll look different for each of you depending on what you use. You could start up here, instead of doing cocci and rods, you could do aerobe, anaerobe, facultative anaerobe, and then go down from there. Yes. Don't need to know it for this test because you don't need to know antibiotics for this test. NPLEX 2 is when you have to know antibiotic susceptibility. In micro, do we use that to identify? Absolutely. So if I'm going to identify my staph and streps, I use antibiotic susceptibility by far more often than even hemolysis. They're not supposed to on NPLEX 1, but remember we had Fabers on an NPLEX 1 test. So could they? Absolutely. Are they supposed to? No. They're not supposed to ask you about treatment for NPLEX 1, but they could, right? Would that likely get thrown out, especially if someone like protests? Absolutely. Because NPLEX 1 is not supposed to be about treatment. Now they could say, well, this is susceptibility, this is identification. They could argue that pathway, but then one would argue, well, you don't need to know pharm for this test. So that's what I would hang my hat on. I wouldn't commit those to memory for this exam. Yeah. I wouldn't waste your brain space. That's what I'm saying. NPLEX 2, waste your brain space because there's a ton of those questions on NPLEX 2. Yeah. Yeah. Yes. Yes. I would say create a flowchart, stick with your flowchart. Hours. Yeah. So use the bacteria from the list I gave you, the gram positives and gram negatives. Know the key factors of those bacteria and their key diseases. That's it. Then stop. If this is your weak area, that's all you should commit to memory. If this is your strong area and you already know those things, then get into the weeds of the specific actions on the immune system. If this is your weak zone, which is most of our weak zones, know the gram positives, gram negatives I put in that PowerPoint, categorize them by these characteristics, and then associate them to a clinical condition. So you can see a picture in your brain of that patient, what that person looks like in front of you. That's your best bet for these type of questions. Because remember, the NPLEX, they're going to give you the diagnosis almost always in the clinical vignette. Then they're going to ask you about what bacteria is most likely associated with this clinical condition, or they're going to ask you they're going to provide you with some type of micro information and want you to identify from that micro information, or they're going to give you the bacteria and they're going to ask you micro information about it. Either way, the answer's in front of you. So no reason to kind of memorize all the nitty-gritty for these. Surface level and key picture associations are going to be your best bet for this micro section. There's going to be some weird bacteria. They'll throw in like I said, they throw in like a leprosy. They love talking about rickettsia. They love talking about Bergdorfia. They love talking about some of those, some more kind of things on the extremes potentially. I mean, we see them a lot, but more extremes maybe. But when in doubt, the majority, the bulk of micro questions are going to be on things that are more commonly seen. And then there's going to be a couple outliers of things that you probably have never heard before, didn't study. And you're not going to be able to be fully prepared for every question they throw you. So when you're getting to massive amounts of knowledge, that's why I say just do your synthesis. If you love micro though, go in the weeds, go for it. I really liked micro, I leaned in, and I think I overstudied for some things and then didn't look at other things. And even in micro, I learned a ton about some bacteria, way more than I needed. And then I didn't look at some of the more obscure ones. So I didn't even have that visual recognition of having at least seen it once before. So don't do that. I still passed. I did great on the micro stuff, but it was one of those things where I was like, oh, I wish I wouldn't have spent as much time learning every endo and exotoxin. I wish I would have just did a first pass through all the bacteria. This is a gram negative. This is more what I threw up here was just what I had. It's more clinical identification if you worked in a lab. So don't pay attention to as much of this stuff. But again, same idea using cocci rods, urease. Again, these things you wouldn't know, like glucose and citrate and MR. But capsulars are not. But this is a flowcharts examples of what you can do to help make a one-page study page on your bacteria. I think it's really helpful to just be able to write them all on one page, have all your gram negatives there. You can even do clinical associations. That might be even helpful. Put all your gram negatives down and then put the most common disease it's associated with. Strep pneumonia, great, done, Staph aureus, skin infection, or endocarditis, done. Okay. It's not worth it. Remember what I told you, you all are probably going to be the best pathologists out there compared to the other schools. You learn pathology so well here overall as a whole. So you know these pathologies, you just have to be able to associate with a cause, with an etiology, with a bacteria. You know the condition. So viruses, again, this is not a virology class, so I'm just going to hit some high points of reminding you about structure and how they infect people, because this will help us differentiate viruses from our bacteria. So our general viruses, we have, here we go, general structure of our virus. We have a capsid. All virals have a capsid. This protein coat that's going to enclose and protect their nucleic acid, their DNA, their genetic components. Each capsid is constructed from identical stuff, identical subunits called capsomers made of protein. Those are called nucleocapsids then together. And some viruses have this external envelope covering. Those that don't are called naked viruses. So here's an example of what I'm talking about. Capsid, nucleic acid. This is a naked one versus this is an enveloped virus. Okay, enveloped viruses. What do we think? If the virus is enveloped, what's it going to be able to do better? Evade the immune system. It has an extra thing around it that protects it, right? Viruses, key piece with virus to just remember, I know you all know this, but it's a good reminder, they can't live without a host, right? They need the host cellular mechanics to survive and replicate. Bacteria can survive and replicate on their own. They sometimes like to hijack our immune system and our cells and our processes of replication. But bacteria can on their own evolve and divide and replicate and grow. Viruses need a host to do that. I don't care about this, but viral envelope, mostly animal viruses, typically acquired when the virus leaves the host cell. And this exposed proteins on the outer layer are called spikes. They're essential for attachment. So again, they're going to help the virus attach and evade and infect the immune system. It's going to protect that nucleic acid so it can survive a little longer outside of a host. And it's going to allow easier transfer of its DNA processes. And just again, to show what we're talking about here, so your capsid head, your nucleic acid. Typically, you have some type of it almost looks spider-like. I always thought viruses always look very spider-like. Viral genome, you're going to have DNA or RNA viruses, but not both. So DNA viruses typically double-stranded, but could be single-stranded. So you can see dsDNA or ssRNA, circular or linear. They love asking about the DNA or RNA quality of a virus. So when looking at your common viruses, creating a chart or creating some flashcards to remember which ones are dsDNA, which ones are ssDNA, which ones are RNA, that would be helpful. I have on there, I've done that work for you. So online, there is a PDF for you that lists the viruses that are DNA versus RNA associated, the ones that are most important to know. RNA viruses are typically single-stranded. They could be double-stranded. They might be segmented. Most are classified by structural makeup. Typically, they're ended in viridae. Do you need to know that? Doesn't really matter. But what are their replication modes? This is important. So there's typical replication modes of virus: adsorption, penetration, encoding, synthesis, assembly, or release. Essentially, though, when in doubt, I just want you to remember that they need the host to replicate. So any condition or any state that they're talking about with a virus, just know that they're going to use and need our own mechanisms to be able to replicate. Where they replicate and how is slightly different depending on the virus, but they're not going to get that into the nitty-gritty, into the weeds. Viruses typically have a spectrum of cells that they can infect, but there are certain cells that they like more than others. So certain mechanics and mechanisms they're looking for. That's why Hep B will typically go for liver cells, hepatocytes. Poliovirus is going to go for intestinal nerve cells. Rabies could go systemically. So based on the symptoms that are going to present from your virus, they might tell you about what cells they like to infect. Our hepatitis virus are going to love hepatocytes. They have a lot of mitochondria in there. They have lots of ability to replicate fast. They have lots of sources of energy close by. Okay, so you can get some information about the replication status of the virus based off of where they like to bind and replicate themselves. How do they actually get through to the cell? Two main ways: endocytosis and fusion. Endocytosis, the whole virus itself is engulfed and carried in via vacuole or vesicle. Versus fusion, the actual virus's envelope merges directly with the cell's membrane and allows for the inside contents of the virus to be emptied into the capsule, into the cell. These are the two main ways you're going to enter: via a vesicle engulfment fully, or actual fusion directly with the membrane and release. When we need to know about DNA and RNA depends on replication and where. So DNA viruses typically replicated and assembled within the nucleus versus RNA via in the cytoplasm. Matters for two ways. One, because when we're talking about killing or eliminating a virus, do we need to actually penetrate all the way through into the nucleus? Or do we need to just get into the cytoplasm and release something into the cytoplasm of a cell? And also, how can the virus get in there? The virus is going to have to get in not only to the cell, but to the nucleus if it's DNA replication. This is going to have more evaders of the immune system, more specialized components of your immune system to actually access that nucleus versus if it's an RNA virus, it can get in easier. If they get in, they must get out. They're either going to butt off and leave the cell alive, or they're going to kill the cell by lysing the cell. So two ways. So some viruses, if they're a lytic virus, they're going to kill their host. They're going to kill their host cell. The cell will die and rupture and release its content. If they're a budding virus, they're less likely, they're more symbiotic with the host. So you could potentially see a budding virus be a virus that you could live with for longer, versus a lytic virus being a virus that's going to cause more localized cell damage and destruction. Probably going to be symptomatic faster and spread quicker with a lytic virus. So we know as naturopaths and as doctors that there can be persistent infections. Some can actually remain latent, which these are ones that are important to know. I mentioned this on a previous slide, a previous presentation, but measles could be hidden in brain cells for many years. Herpes simplex, HSV, cold sores and genital herpes, herpes zoster, chickenpox and shingles. These like to hang out in different cells within the body. Epstein-Barr also likes to hang out for a while. We now think COVID probably does the same thing. HPV. So a lot of our viruses like to stay and hide out and divide and live as long as they can. Symbiotic relationship. So one thing that I think is important to touch on is bacteriophages. So bacterial viruses or phages, the most likely studied are those that infect E. coli. So this would be bacterial viruses that actually infect the bacteria themselves. This is where we can have that bacteria transfer of DNA through a virus tool. This is all of these bacteriophages are lytic, meaning they're going to apoptose or destroy the cell they've replicated within. So what I'm going to do here is I'm going to pop out of this one. Perfect. And I'm going to pop into this dude. Nope. Do I have it open? Viruses, fungi. Sorry, folks. There we go. Okay. I wanted to just show a little bit about some of the big viruses we need to know. Of micro things to put to memory, bacteria would be my number one, virus number two, parasites number three, fungi number four, prions number five. So if you're prioritizing your study, I would hit bacteria first, virus second, parasite third, fungi fourth, prion fifth, if you hit all of them. That's typically is your percentage or kind of your likelihood of seeing them on the test. If you don't hit them all, that's fine. Get through what you get through and move on, right? So this is, I think this is labeled as virus part 1, but this provides you with a list of all the major DNA viruses that could come on your NCLEX exam or would be more likely to come on your NCLEX exam. This is showing where the virus is and where it's likely to potentially affect you. So these pathogenic viruses, so these are based off of system. So this might be a good way to kind of learn these viruses first pass, is because then you can associate with clinical condition, right? So what is the virus? Molluscum contagiosum. Where is it going to affect? Skin, skeletal, or urogenital, right? Herpes simplex, we can see oral herpes, Whitlow's, keratitis, encephalitis, or genital herpes. So varicella zoster. So I would look at this and start here if viruses are not your thing. If you already know the clinical and locations of these common viruses, then you can move into more things about the viral cycle replication or how the body's going to respond. But I would start with here, the virus itself and where it's affecting the body, because that's your clinical association. Do you know these? Epstein-Barr, mono, you got that. Cytomegalovirus virus, salivary glands. VZV, chickenpox, shingles. We get into some of the interesting viral exanthems. They love asking about those. So like human herpes virus 6, HHV 6 and 7, roseola. There was definitely, this might have been NFlex 2, but it could have been NFlex 1. There was some questions about measles, mumps, rubella on there, those viral exanthems. So if you had to study one set of viruses, maybe knowing how to differentiate between those, I think would be your best bet. But you do though. Yeah, absolutely. Yeah. Yeah. This is virus part 2 or part 1. We don't have that much longer. That's why I pulled this up, just to show you these tables, because I think these are helpful study tools for you all. Okay, I'll make sure these are shared. I might just not have gotten to uploading them yet. Yeah, I will share them all. The other piece of the puzzle here that I think is helpful and what I've gotten there for you is we have this categorization here. So if you know their clinical locations, right? So learn those first: virus, clinical location, and condition. Then if you are feeling so excited, then think about enveloped versus non, and then your double-stranded versus single-stranded genome, okay? These would be secondary study goals, though. These are not primary study goals. Primary study goals is virus and condition or virus and location. Then enveloped and non-enveloped or double-stranded and single-stranded would be your 2 other clinical components that'd be important for viruses, specifically DNA viruses. From there, I would probably stop there. That's as in-depth as I get for your DNA viruses. Any further, and you're going to be getting too into the weeds. This presentation, though, does go into each virus and kind of some of their clinical conditions. So if there is a virus that you haven't heard of before, this might be a good place to review. It also gives some pictures. So if you're a visual learner and can like create a patient, that's why this exists. Okay. I'm going to go through the other resources I'm putting up here just because we only have 10 minutes left. So I just want you to see all these. I didn't expect to get through all these today at all. So that's why there's more than what we could get through in class, but I want them available to you so you can start studying from them. All right, so this is that was viruses part 1. RNA viruses is also one, which I'm opening right now, but I'm first going to open your parasites. Just because I already have that open. So parasites, I also have here for you your common medically potential parasites you might need to know for the test, and then where they're located or what condition they're located with. I would say on this list, Entamoeba, Histolytica, and Trichomonas and Giardia would be your 3 big here. Leishmania, Plasmodium, Toxoplasma, and Cryptosporidium would be your important ones here. Then it breaks it down based off of more types, right? So again, just like I said with viruses, do the same thing here. Get them first associated with their pathology and location. So get that clinical picture first, because that's going to be your best way of memorizing them, because we're clinical people. Then if you want to, you can think about your amoeba, your ciliated, your flagella, but that's secondary. That's if you already feel like you know the clinical associations. If you don't know the clinical associations, just stick to clinical associations and stop there. They are not going to ask about the structure of a parasite, likely, on the test. That'd be very rare, right? Is it flagella? Is it amoeba? less likely. Now, if you understand those things that can help you remember the clinical characteristics, great. Then you're a step ahead of the game, right? Then you use that to your advantage to remember clinically. But if you don't worry. Anything related to drugs, don't think about for this test. If they include a drug on there, it'll likely get thrown out as a question. And then again, I also should go through each pathology and talk about kind of its pathogenesis. So you do have kind of what that looks like if you've never heard of some of these conditions before, which I understand some of them are weird. And like I said, the last one I would want you to look at is fungi and protozoa, or prions, sorry, fungi and prions. And fungi, I also have your disease and your habitat and distribution. So histoplasma, blastomyces, when they have fungi, they tend to have it on with a bacteria and ask a question like, what bacterial infection causes this? And they list 3 fungus and 1 bacteria. It's the only bacteria there. Or they'll list which fungi causes this. And then there's 3 bacteria or 2 bacteria and a virus and 1 fungi. So if you can have some recognition of what these are, which ones are fungus versus virus versus bacteria, you're going to be ahead of the game, even if you don't exactly know all the ins and outs of what that fungus does. Then if you can associate with a clinical condition, you're ahead of the game. Okay, so again, that's going to be your best, quickest way to get these into your brain with 2.5 weeks-ish left, 2 weeks left in studying, right? Which you are all going to be fine. I would say here, our secondary opportunistics are going to be the most important. So your Candida, your Aspergillus, and your Pneumocystis. These ones have come up before because we can see them commonly clinically or more common clinically. Again, name recognition, recognizing where they're going to affect you or what some of the clinical associations are. Like this is upper respiratory tract. This is the most likely associated with like mucosal membranes. And then the last one I had for you, and again, I'll make sure all these are posted. I believe almost all of them are, but some of them, 1 or 2 of them isn't, because I wasn't quite so fast this morning, is your RNA viruses. Your RNA viruses here, same. I provide you with the picture, your little table. So if you know influenza and influenza, Hanta, that probably wouldn't be on to influenza, para, mumps, RSV, rabies. I don't think they'll have COVID, Hep C. Unlikely, but maybe, but unlikely for these 2. HIV, Hep A, rhino or noro, they like those. I've had a question about Ebola or prions before, but again, less likely. So with these ones, if you can do some association with clinical condition, you'll probably be fine. And I do break things down. So if you do want to see more specifics about each condition, you can get into as much in the weeds as you'd like. But again, I would go very surface level to start with, focusing back time most on bacteria, second most on virus, third most on parasites, and then last on fungi. The charts I was referencing to earlier are here. So I have your gram-positive bacilli, your gram-negative bacilli, your gram-positive and gram-negative cocci. Those are all listed there for you. There's a table up front that associates them with medical conditions first. Start there, and then you can get further into their more bacterial characteristics as you feel you're able to. This miscellaneous bacteria presentation here, miscellaneous bugs, is bacteria that can't really be well classified into gram-positives and gram-negatives, okay? Again, if you're just like, I don't care and I don't want to focus my study on this any more than I have to, there are also on your Moodle page already created flashcards that you could just plug and play. So I'll pull them up just so you know. Because sometimes we just can't make our own. I get it. I'm moving it over to show you. Okay, nope, come on. Sorry. Move over. There we go. Okay. Oh gosh, stress. There we go. Okay. All these links here are flashcards that have been shared with me from previous peeps that I actually think are good. So this one here, micro and immuno, is a good collection of different bugs that you could study. So if you are just in the point where you can't make your own study materials, I would start there. I believe you can have access through my link for free to Brainscape. You won't get all of the, like, you can't edit the cards or anything unless if you actually have your own Brainscape account. If you want to edit and share your own flashcard decks for others, I do think you have to pay for Brainscape, but otherwise I think you can have this access for free with this link. This is just access to my flashcard decks. Okay. Don't let micro defeat you. You got this. All right, we are done. We are done with time for the day. I will make sure all the presentations available to me are available to you. Tomorrow, we're going to have a practice test at the beginning. We'll go through the answers like last time, and then we're going to do MSK. Thursday, we will go into neuro. And then Friday, we're going to touch on the last few things. So integument, blood, and repro. And then that's it. Go forth and be awesome. You got this.
Thanks, Dr. Petch.